Thank you to FAER and the MSARF for the opportunity to speak with you today about educational research in anesthesiology, including research on residents and ethical considerations. My name is Julie Huffmyer, and I am from the University of Virginia in Charlottesville. In preparing for this short talk, I looked back on some of the research projects that our team of education researchers has done at UVA over the past several years. I want to acknowledge and thank them for all of their hard work and collaboration. As far as disclosures, I have no personal financial, consulting, or contractual relationships with any vendor. When I was asked to participate in this panel, I was excited and then immediately anxious. I thought, what would a smart and energetic group of medical students want to learn about education research? I then laughed to myself as I thought back to being a medical student and being completely oblivious to the academic pursuits that were going on around me. With all that said, what educational talk would be complete without goals and objectives? Today, I want to share with you a bit about my background and the path to this point in my life. I also want to define the current state of educational research and research on residents. I want to talk a little bit about the important questions that need answers and some opportunities for the future. I also want to share some of our education research group projects with some of our mistakes made and lessons that we've learned. And finally, we'll finish out with ethical issues in education research. Every year at our anesthesia residency graduation, I say the days of residency are long, but the years go by so quickly. The same thing can be said of being an anesthesia attending. I look back and I can't believe that my own residency finished nearly 12 years ago, and I've been out of medical school for 16 years. The years indeed do fly by. For those of you out there who might be on the non-traditional path, I started my career as an ICU nurse in a cardiothoracic surgical unit. I loved my job, but I wanted to pursue medical school. I just wanted to be able to do more. I went to the University of Pittsburgh and enjoyed most of my rotations, which made it very difficult to choose a specialty. I ultimately chose anesthesiology as I was searching for a place in medicine that I could make a difference. A fast-paced environment, I loved hands-on work. I also liked the flexibility that anesthesiology offered me. I matched into my first choice of anesthesia residency program at the University of Virginia, where I also completed a cardiac anesthesia and liver transplant fellowship, both of which were unaccredited fellowships at the time. My current roles include being an associate professor at UVA and being the residency program director for the past 4 years. I was the associate program director for the previous 5 years to that. I have always been interested in education as long as I can possibly remember. I have wonderful support systems. I have a great family, my husband and 3 kids who are pictured here now as teenagers, and of course, aging parents, which also adds stress to every system. People are most important in life. I didn't really get to the point that I am now without the help of others. Early on, my parents were the best teachers. They always taught me to work hard, say yes, and find a way to excel. My current chair is Dr. George Rich, and he's pictured here on the left. He's invested mightily in my success. He's been an incredible support to me as a young woman in anesthesiology. The guy on the right is Ed Nemmergut. He is my mentor and friend. I think of him as one of the best teachers I've ever known and as the original education research expert. I'm the teacher, researcher, and program director that I am today as a result of his mentorship. Ed also leads our education research group. Dr. Karen Schwenzer in the middle here is my good friend and colleague. She is the one person who, as a retired anesthesiologist, reads and critiques my manuscripts. There was a time when she was one of 2 female faculty members, and she has been fantastically encouraging to me as a woman in medicine and anesthesiology. The bottom picture was taken of our graduating residents just a month ago. Without the residents who are willing to work with us and to help us get projects done, there would be no research on residents. In relation to other fields, both in medicine in general and in anesthesiology, education research is really in its infancy. There are so many avenues to take and so many questions that need to be answered. It's easy to get overwhelmed, especially when considering where and how to get started. There are bodies of emerging and fairly stable research on simulation education, educational techniques such as flipped classroom and generative retrieval, adult learning theory, and the impact of medicine and residency training on life and learning. So why do education research? It's important to remember that as adult learners, we don't really understand how we best learn and assimilate information. You and I are not a computer hard drive that simply just stores information for retrieval at a later time. Our minds have a remarkable ability to learn, to forget, and then to remember again. Forgetting does not actually undo learning, but instead enables learning and focuses the mind on the task of remembering. Remembering creates opportunities to learn, but yet produces forgetting. Thus, conditions that create opportunities to forget produce opportunities for learning. Ultimately, as educators, we want to improve learning opportunities. Then, finally, there's an increasing focus on the interplay between education and patient safety through education research. Now that I've convinced you, hopefully, that you should consider studying how you learn best, unfortunately, many of the methods of education research are flawed. The methods of education researchers are often based on assumptions and misunderstandings, and I think one of the biggest fallacies is that learner satisfaction is linked to improved education or knowledge retention. Often, the more uncomfortable you are as a learner, the more you'll actually remember. This is why the classic attending pimping on word rounds works for you to retain more of what's going on in your medical school rotations. Scientifically rigorous methodology is vital for all areas of research, but is often missed by education researchers. As a reviewer for the medical education section of anesthesia and analgesia, one of the biggest issues we see is that many researchers base their education studies on surveys that are put together without appropriate survey methodology and validation, based on opinion, experience, and satisfaction questions. Thus, education research is hard to do, and I want you to remember that. Good education research is very hard to do. It requires time, patience, and rigorous statistical analysis, and often the help of a statistician or data scientist at the start of the study. It's vitally important to begin study planning with a hypothesis, a clearly measurable outcome, and a power analysis. I call this slides Ed's Education Research Quadrants. As I mentioned in the beginning, my mentor is Ed Nemmergut, and he's the leader of our education research group. He's adapted Stephen Covey's 7 Habits of Highly Effective People to our education research group. We talk routinely at every meeting about what's important and impactful and what is doable and how much effort is required. This is really a great framework for how to decide which studies to do. You want to focus your efforts and your work in quadrants 1 and 2. Quadrant 1 you can see is a low effort and important or impactful study. So these are the low hanging fruit studies. These are things you want to do now. And unfortunately though, they are very few and far between for us. Quadrant 2 is high effort and high impact or importance studies. So these are things that require long-term development. They take time, lots of effort, and lots of hard work, but at the end of the day, when one of these studies is done, you have something. Quadrants 3 and 4 are low effort but not important, or high effort and not important, and those are not places that you want to spend most of your time. The potential list of opportunities for research and education is endless. Some investigators have a pretty broad or pretty strict definition of education research, meaning what are the techniques to improve and increase learning and retention, and those are the ones that should be studied. Others, like our group, have a much broader definition of research and residency, including anything that affects life as both personal and professional considerations impact learning and education of residents. I want to highlight just a couple of these out of this list. So novel educational methods and tools for learning, including newer anesthesia techniques and areas of expertise, are areas that are wonderful for education research. And so one of the most common that I think of in the last several years is how ultrasound has become ubiquitous. And so it's a wonderful place to study education research. Other initiatives are things that are brought about by credentialing boards, like the introduction of the applied exam, which includes an OSCE component by the ABA. Generally speaking, those things change practice or change the way we educate residents and provide an opportunity to do some education research. I want to share a little bit of our work under the framework of mistakes made and lessons learned. There's no study that's perfect. It's important to work out as many of the details ahead of time that you can, but there are definitely limitations and you're going to miss things. If you spend all of your time making a study perfect, you're never going to actually get it done. Research always takes longer than you think that it will, and so it's important to plan for extra time to be required. Dealing with IRB's issues, this is all of research is challenging at its best. one of the pieces of advice I give to junior faculty who are maybe doing their first investigation is to make the phone call to the IRB contact person. It's much easier to explain in person what you want to do and ask your questions in person than to send an email with a chance for being misunderstood. The other thing that's a really, really important and a very, very good lesson is to be creative and to think outside the box. For us as faculty researchers, that means getting residents involved in what we're doing. On the beginning part of a study, on the planning part, are we proposing feasible initiatives? Are they important and impactful? Do they matter to residents? And are they generalizable to other groups or bigger groups of residents? And again, a reminder, it always takes longer than you think. So we're going to focus a little bit on some of our education research group studies. First, some learning methods and then fatigue studies. There's evidence that repeated testing and even self-testing enhances long-term retention of information and knowledge due to the practice of retrieval from memory. Generative retrieval is a method of studying that requires the learner to generate an answer from memory or cues prior to studying or even being taught the material. Our first study's hypothesis was that among novice transesophageal echocardiography learners, so fourth-year medical students and interns prior to any cardiac or cardiology rotations, a generative retrieval group would have increased intermediate and late retention of TEE cardiovascular anatomy compared to standard practice. I want to show you some real examples or real images that were seen by participants in our study. This is the standard practice group, and I'm going to let this play out because the standard practice group viewed a labeled image for a total of 15 seconds, as is seen here. The generative retrieval group viewed an unlabeled image, like the one seen here, for 10 seconds. Then, during a blank screen, the generative retrieval group was asked to identify the structure. After answering, they were shown the correctly labeled image for an additional 5 seconds. So each group studied for the same amount of time. Here, the results are depicted graphically with the generative retrieval group in red and the standard practice group in blue. Indeed, we showed improved 1 week and 1 month follow-up scores in the generative retrieval group as compared to the standard practice group. I would love to present our subsequent generative retrieval studies, but I'm running out of time. And so perhaps I can answer questions about these two studies later in the QA session. Importantly, one of the things to remember is that subsequent studies can cause a revision in your hypothesis as results may change when you repeat studies in different conditions and different circumstances. Our driving studies after night float evaluated driving performance in a high-fidelity driving simulator that's pictured here at the bottom left. Our first study in the top left showed quite reckless driving after 6 nights of night float and an inability to control speed, lane position, throttle, and steering, as well as an increase in collision compared to residents who drove in the simulator during the daytime period. One of our main mistakes in this first study is that we didn't randomize the order in which residents completed the study, so that while each resident functioned as their own control, doing the drive both after night float and when they were on day shifts, the impact of quote-unquote learning the course was not controlled for. Additionally, some residents, despite being instructed to drive at 45 miles per hour for the 45-minute course, drove as fast as they possibly could the entire time. For our second study, on the bottom right, we wanted to look at the effect of caffeine. Caffeine pills would have been the best intervention to use, but that would have been challenging to get through the IRB and would have required the use of an investigational pharmacy. We really wanted to use brewed coffee, as that is what many people reach for when they're fatigued, but the caffeine content is quite variable based on water content and brewing methods. So we elected to use the Monster energy drink versus the Monster unleaded energy drink. Again, no study is ever perfect, and it's important to be creative in dealing with a lot of the challenges. Nonetheless, we were able to show improved driving performance with the caffeinated energy drink ingestion after night float. In that early period after ingestion of caffeine, some of the driving was actually more erratic, with the thought that caffeine actually induces anxiety and tremulousness. But those folks after the caffeine had taken effect a little later had improved driving performance. Two of our major limitations and lessons from the driving study are this: not all residents have to drive home, especially in urban hospital settings, and so that represents a lack of generalizability. It also would have been fantastic to have done a simulated patient scenario for both of these studies. While driving safety is important, one of the unstudied pieces here is what role fatigue and caffeine play when it comes to safe care of patients in the operating room. So after those kind of personal research group experiences for us, let's get back to a little of why to do research in medical education. So education research helps us develop a body of evidence on which to inform educational policy at the level of accreditation organizations like the ACGME. There's also pressure on GME funding that requires education to be efficient and effective. Thus, everyone wants us to do more with less time and money. So research, education research, will help us identify optimal approaches to educating the future generations. My final objective is to discuss a bit about the ethics of education research. This could be a topic for an entire day symposium, and it's challenging, I want you to understand, to be a program director and an educator who has authority over residents and evaluates them, yet has a deep desire to study the effects of residency training and educational initiatives on residents. Residents are a vulnerable population. They're often widely dispersed and not available. That really limits obtaining an adequate sample size. Funding is also scant, and education investigators are often required to get departmental or local support to do studies, and that's typically reserved for more resourced departments with good chair support. Central to discussion of the ethical challenges of education research are the concepts of informed consent and coercion. Residents, again, are a population of convenience and a captive audience. This makes them very vulnerable, and that vulnerability relates to the status relationship between researcher and participant. Residents may feel that it's in their best interest to participate in a study, or they may feel pressure to do so. That status relationship is quite dynamic over time. The effect weakens or is reduced as residents ascend the training ladder, such that by the last year of residency, they often feel very comfortable declining to be in a study. One of the methods to get around issues of coercion is to consider a generalizable intervention that's not specific to a single group of resident trainees like anesthesiology residents, but that can instead be rolled out to many resident groups. This helps to limit the effect of coercion on a single specialty related to the researchers. Additionally, multi-center studies often help with this. Risks to residents may actually be quite significant. Participation in studies may yield loss of time to do other things like rest or relax or even study. It may also yield unfair advantage to some residents who participate while others choose not to. Residents may experience loss of privacy and an impact on their reputation and career as a result of participating in studies. With all those issues in the background, how can we do education research well? I think team-based research is a great option. As faculty, none of us actually are responsible for consenting or even inviting our residents to participate in studies. Those resident-facing tasks are reserved for a non-physician member of the team. Participation must always be voluntary and anonymous to the research team as to who did or did not participate, and that can be quite challenging in small studies, small programs, and small departments. There is also a definite need for regulatory oversight. At UVA, for example, prior to a study being able to even be submitted to the IRB for approval, a graduate medical education committee with research training reviews all studies that involve trainees, and an undergraduate medical education committee reviews all studies that involve students. The job of these groups are primarily to evaluate for coercion, informed consent, and anonymity. Lastly, some of the work of education research can be accomplished using a quality improvement approach which does not have the same standards as project-based research. Unfortunately, the desire to publish a study usually necessitates the IRB process. Thus, in summary, there are lots of opportunities to do education research and many paths to take. It's challenging to do good or rigorous education research. Perhaps most important is choosing impactful projects with a hypothesis and a measurable outcome. Mistakes will happen. You will make them. You must own them and learn from them and move on. Ethical issues abound in research, including informed consent and coercion, and these must be mitigated as much as possible by researchers. As a medical student 20 years ago, I never would have guessed that I would be here as an associate professor, just having received a research grant in education. There will be many stresses at each step along your way. Just do your best every day. My advice is to be open to new ideas and opportunities. Saying yes opens up a world of possibilities. Thank you so much for your attention.